Podcast is now starting. All attendees are in listen-only mode.
Well, welcome everyone. Thanks for taking your time this evening to talk to us. I'm Dr. Guy Qrst from Dental Sleep Solutions in DS3, and I'm just entirely honored to have with me a friend and mentor, Dr. Jamison Spencer tonight. We're gonna talk about TMD. Jamison, I'm just thrilled to have you on here. I just can't say enough nice things about what you know and how you deliver those messages to dentists wanting to get more involved in TMD. So welcome.
Thank you. Thanks for having me.
I'll talk more about Dr. Spencer in just a moment. We'll do a little housekeeping first here. Just if you're tuning in and you want CE credit, just you'll get an email within a day that has this email, has the CE credit there. If for some reason you don't see it, please check your spam, because that's where it usually ends up when people can't find it. So that's pretty much it for the housekeeping. We're going to keep it to an hour tonight. There's question box. We asked if you have questions, type those in, and we will be answering those as we go through. And then any ones that we haven't gotten to as far as typing the answers back, we will verbally answer. Dr. Spencer will go through those at the end as well. So just keep the questions in the question box, and we're going to get going. I don't really think Dr. Jamison Spencer needs an introduction. I think most of people who are in the dental sleep and TMD world know who you are. I can just say that having known you for a few years now, that my TMD knowledge was fairly decent to start with, but I just really appreciate the way that you give your lectures, how you make these processes more simple, simplify the way we do our histories. And I want to also thank you for your help with our new TMD module that we're launching. You really took your time to help us make sure that was something that'll be useful. So thanks a lot. I'm going to hand it off to you. I'll chime in when I have some questions, but pretty much your show tonight, buddy. Thanks for joining us here.
Excellent. Well, thank you so much, Guy. It's always a pleasure to be with you, even virtually, and look forward to seeing you in the flesh here in a couple days in Baltimore. So we'll get rolling. I don't know that I'm going to be able to see the questions coming in. So, Guy, if you see those, go ahead and you can just interrupt me, and we can take questions as we go. I think that'll be most effective. But here's our goal tonight: is oftentimes, in dentistry, think about this. Is diagnosis usually the hardest part, or treatment? Now, if you're at home, you're probably immediately thinking diagnosis. And while that is definitely true in certain cases and in certain fields of dentistry, in bread and butter dentistry, actually, I would say that treatment is oftentimes harder. For example, if I get up before y'all got on here, I had a little accident here in this room. By the way, if it looks like a little bit of a mess behind me, it's because there is a mess behind me, because my family and I are moving in a week, and also getting ready for Baltimore and everything else. So it's a bit chaotic here. But anyway, something happened. Let's say I would have fallen down and hit my tooth, boom, here on my desk, and broke number 8 halfway up. Just 8. And what would the diagnosis be? Well, I'm pretty sure I could go outside and ask my next door neighbor what's going on, and my next door neighbor would probably say broken tooth. And that would be right. He's never been to dental school. He has no clue, but his diagnosis would be correct. Now let's get to treatment. Which one of you on the call is going to fix number 8? And here's the rules. Thou shalt not touch number 9, nor shalt thou touch number 7. And I don't know if you recognize me or not, but I do a lot of stunt double work for Thor. So, this is important. Who's taking that on? Probably very few of you can match number 8 exactly to my virgin number 9. So the art and the science of treatment is very, very complicated. Sometimes the diagnosis is hole in the tooth, and then the treatment is how do we restore that. Sometimes the diagnosis is space. How do we restore that space? And with TMD, on the other hand, and in most areas of medicine, it's sort of flipped. The diagnosis is hard. In medicine, meaning medicine is kind of broken into two sides. There's medicine and surgery. And on the surgery side, that's us. We're actually on the surgery side. And most surgeons, ear, nose, and throat doctors, orthopedic surgeons, they're kind of more like us. Diagnosis is usually pretty clear. Broken bone. Okay, yeah, broken. Anybody, any idiot could look at an x-ray and go, that's a broken arm right there. Now, how do we fix it? That's where we get tough. On the medicine side, as you all know, sometimes that diagnosis takes forever. Sometimes they never get to a diagnosis. They just treat based on empirical information and see how the patient does. And sometimes the diagnosis is made by the reaction to different drugs. This TMD stuff oftentimes has fallen onto the medicine side. And this is why it's so confusing for us and so out of our world, because all of a sudden the diagnosis is really difficult. But if we can figure out the diagnosis, if we can figure out the true etiology, treatment becomes a snap, just like it is in medicine. If they can figure out what bug is causing that infection, they hit it with the antibiotic and they're good to go. If they can figure out what process is going on, the treatment becomes pretty easy and it's delegated. The treatment then gets delegated to someone else. Again, that delegation may be a script to a pharmacist who counts out the pills and gives it to the patient and they're good to go. In my office, that delegation is my team fitting the oral appliances and doing things like that. And the doctors in our office are really there to diagnose, refine our diagnosis, and make sure treatment is going well. So what I want to talk about tonight is a way to help you in your diagnostic skills when it comes to temporomandibular disorders, and also to specifically talk about a couple, not a lot, but a couple of the most common temporomandibular disorders that you're going to see. And so that's what we're going to do. So I titled this, The Mystery is in the History. And this is really true that we're looking in the history and the patients will give us this information. Now, I like to say I would suck as a pediatrician, or especially a one seeing babies. I could probably handle seeing teenagers because I see teenagers. I would suck as a veterinarian. Okay, the horse can't tell me where it hurts. I would have to pull that up. I need my patient to tell me. I need my patient to tell me stuff. And then through my experience of treating thousands of other patients, I've seen the patterns that exist over the years. I know what to expect because I've seen it over and over and over again, just like you have restoratively. You know exactly what to do when the person presents. That's the way it's become with me with certain TMJ problems. All right, so let's get rocking here.
Hey, Spencer, I'd like to add while you say that when you're doing your fees and you're getting paid, I think this is really a lot different as well. We're used to getting paid for that procedure, for that bonding, as your analogy goes. And I tend to gravitate towards the business aspect of a lot of things when it comes to dentistry. And that's a really difficult thing for some dentists to get through their minds, that we're getting paid for making that diagnosis, for helping and sometimes we miss the diagnosis and we're getting paid all along as we're treating the patient. We're not getting paid for this crown or bonding or whatever we end up doing.
That's right. Yeah, thank you so much, Guy. An analogy I use sometimes with my patients is, you're not paying the surgeon for scalpels and sutures. You're paying for that skill to use those tools. You're not paying the neurologist for their signature, because that's, ultimately that's kind of what they get, is the signature, so that they can fill a prescription at the pharmacy, but that's not what they're paying for. They're not paying for a piece of paper. And I say that all the time. You're not paying me for plastic. Plastic is a tool that I use, but you're paying me for the skill and expertise and experience of how to use that piece of plastic, not for the plastic. So we're going to talk about something called Opie Qrst. And if any of you on the call tonight have a medical background at all, like nursing or something like that, you will be familiar with this. So this is not something Jamison Spencer made up. This is something that medical professionals use every day. If you were to go into the ER tonight, they're going to roll you through this Opie Qrst. And so what is that? So O is for onset. When did the problem begin? P is palliate or provoke. What makes it better? What makes it worse? The pain or the problem. Q is quality, R is region, S is scale, and T is time. So we're going to go through each of those. So onset, and we're going to obviously talk specifically about jaw problems because that's what we do here, right? So what were you doing when it started, and when or how long ago did it start? So I would propose to you that there's a major difference between someone who says, I've had TMJ since I was 15 and now I'm 50, versus someone who says, my jaw hurts and it started last week when I got hit in the jaw playing basketball. Those are way different patients, and the treatment is probably going to be very different for them too, and the outcome is likely to be very different with them as well. Little aside there, sometimes you'll have patients that have had a problem for a long time, and we'll talk about this at the end on who not to treat. But sometimes I've had to use the phrase, you know, how long has this been bothering you? Well, it's been bothering me about 10 years. And I will say, you know, I need just as long to get you better as you've had your problem. And then they'll that'll take them aback, right? And I'm like, okay, probably not. But here's the deal. What took 10 years to create, I probably can't get better in 10 days. I'm going to need you to work with me here and do what I say and work with maybe some other practitioners to help you out. It's taken 10 years to get here. I probably can't get you better in 10 days. Another thing on that, patients like to blame their problems. And we've got hundreds of people on the call tonight. If y'all could take an oath for me, here, let's all do this. Raise your right arm to the square and repeat after me. I will never throw my dental colleague under the bus again.
Absolutely.
I will never throw my dental colleague under the bus again. Almost every day in my practice, I have the opportunity to throw orthodontists under the bus because almost every patient wants to blame their TMJ problem on their orthodontics. Now, they didn't make that up on their own. They usually get that from their dentist. And their dentist, oh yeah, you had extraction orthodontics, or you had this, or you had that. That's what caused your TMJ problem. I have, now this is lucky, so I have extraction orthodontics and I don't have a TMJ problem. So it's not everybody. It's not a universal rule that that's going to happen. But the bottom line is, don't throw your colleague under the bus. That is bad for everybody. I know somebody that does dental sleep medicine, and he's having a kind of a lawsuit problem right now because a patient was told by their dentist that this doctor's sleep apnea appliance caused the TMJ problem, which is absolutely not the case. So let's don't throw our colleagues under the bus on that onset. When patients try to sucker me into that, you know, hey, yeah, this all started when I had my mouth open for 3 hours at Dr. Yatros's office. I'll be like, yeah, you know, having your mouth open for 3 hours, that's something you don't really ever do in life. What were they doing? Did they just have you open your mouth for 3 hours for the fun of it, just to see how long you could have your mouth open? Well, no, they were doing a root canal procedure, and it was really complicated. Okay, yeah, so I'm pretty confident that they wanted you out of there as fast as possible. So that's really, you're really lucky that they did such a thorough job to get everything they needed to. That's really good. Let's see why your anatomy allowed this to possibly be related there, because usually it's a straw that breaks the camel's back. It's kind of like, you know, the person that hurts their back, they're usually opening, you know, they're getting milk out of the fridge. Right. It's not like they're power lifting 300 pounds, right? Right? That could be what's going on with you, is you have an underlying weakness there, and that was the straw that broke the camel's back because you had a necessary dental procedure done. So anyway, you can listen to all that again when you listen to the recording, but the reason I can just spit that stuff off is because I do it every frickin' day. Because every patient wants to blame their dentist, and I'll have none of it. Yeah. It's not the dentist's fault. In 20 years so far, I've not seen a case where the dentist was the etiology of the TMJ problem, that the dentist smacked the person in the face or something. All right, so onset. What were you doing when it started? I was chewing, I was stressed, I was opening wide, I was throwing up, I yawned big, I was at the dental office, I had just got my braces off, I just got some veneers placed. Try to see what is the onset and if that makes sense.
And I assume there's times where they don't recall. especially when it's been a long time, and you got to spend a little time with them to, what do you do in that situation when they say, I don't know, it's just been that way a long time?
Yeah, that's a good question. And sometimes also, Guy, it's you won't go back to a what. So then on the onset, it would just simply be, onset was 20 years ago, and don't know, or I've just always had this. And I'll usually, if they say I've always had this, I'll break it down a little bit more. I'm like, well, as a teenager, did you have it? Could you eat whatever you wanted as a teenager? Did your jaw pop and click when you were 12 years old? And they'll be like, well, no. Yeah, it probably didn't start till high school, or it didn't start till college or something like that. So I'll make them narrow it down a little bit. Another analogy I use, because sometimes, again, they will want to blame something that's way long ago. Again, the braces thing is a classic. So they got out of braces when they're 15, they're 35 now, they're having a problem. They still hold this grudge against the orthodontist from when they're a teenager. And I'll say, it's possible, because I'll agree with them. I won't say, no, you're an idiot, that wasn't it. I'll say, it's possible that did have something to do with your problem. Here's the deal, though. It's kind of like you're standing up at the top of a really steep precipice, not a cliff, but a real steep hill. And somebody came along and pushed you. And you kind of have rolled down this hill, and you've hit rocks and briars and thorns and stuff all the way down. And here I'm finding you now 15 years later, and you're bruised and broken up and everything else. And you know what? Frankly, it doesn't matter who pushed you. We got to deal with what we got to deal with here now. Who pushed you is inconsequential at this point. So that's how I handle it, Guy.
Very good.
All right, next, provocation or palliation. Does anything make it worse? Does anything make it better? So on provocation, they may say, well, chewing makes it worse, or stress makes it worse. That's a very common one. Or maybe sleep makes it worse. Now, that's a weird one, right? So if somebody says, yes, sleep makes my jaw problem worse, and I know that we've got a lot, probably most, if not all, of the people on the call tonight do dental sleep medicine. That should be a big red flag of why would that be? Now, one thing I haven't mentioned yet is right now, probably anybody who even implies that they have a TMJ problem, you give them the universal treatment for TMJ, which is a nightguard. Right? Everybody needs a nightguard. Even if their jaw only hurts at 3 in the afternoon, let's give them a nightguard. And that's not the case. It just makes no sense. That's like if I went to I'm a runner. Let's say I go to the doctor and I say, hey, my knee's hurting. And he's like, well, when does it hurt? Oh, well, when I run. He's like, okay, cool. Wear this knee brace when you sleep. Be like, serious? When I sleep? Yeah. What about when I run? Well, I don't know about that. Yeah, you don't want to do that, but you go ahead and wear it when you sleep. And that's how we've treated TMJ problems over the years, is we just, let's try a night guard because I don't know what else to do. And then sometimes it works and we're like, yay, and we have no idea why it worked. And then sometimes it doesn't work and we're like, boo, and we have no idea why it didn't work. So that's what we're doing here tonight, is to try to refine when you might do something. And this is important. It hurts when I eat. Well, maybe that has something to do with your diagnosis. It hurts when I'm under stress, and note the person under stress is clenching their teeth together. Mm-hmm. Or it hurts when I sleep and wake up, wherever is going on. Now on the palliation, it might be the opposite of what they said hurts. Like, for example, well, maybe Advil makes it better, or Percocet makes it better. That's an immediate refer. If they say Percocet makes it better, that would not be a patient I would be working with. But medications might make it better. And even that can be helpful. Is it, well, Tylenol makes it better, or Advil? Well, kind of Tylenol seems to, Advil really doesn't help. Well, Advil's an anti-inflammatory, Tylenol's a pain reliever. Maybe that's giving you a clue into your diagnosis there. They may say a soft diet, or they may have been told by their dentist to eat a soft diet. Or they may say relaxation makes it better, less stress, that type of stuff. So again, you're looking for what makes it worse and what makes it better. Don't be surprised if sometimes when you say, well, what makes it better, the patient either says nothing, or they say, well, not chewing hard foods, not being stressed out, not whatever. They'll just give you the opposite list of what makes it worse. All right, quality. This is, can you describe the pain to me? Is it sharp, dull, constant, intermittent, throbbing, electrical, achy? Okay, and you just kind of throw out those different qualities, and then the patient will tell you. So they'll say, well, it's a constant stabbing pain. And then you say, really? And you don't say it like that, but you'd be like, huh, constant and stabbing. So those two don't go together, actually, because if it was constant and stabbing, you probably aren't sitting in a dental office. Unless it's your tooth, and then you're there to get it taken care of right now. But if it's a muscle, if it's your joint, that'd be weird. If it's a headache, you're probably at the ER. So you need to then say, well, constant? So always stabbing? Or it's kind of achy, and then sometimes it's stabbing. Yeah, it's kind of more like that. It's achy, it hurts all the time, but sometimes it's really stabbing, or sometimes it's electrical. So electrical and constant, that also wouldn't go together. A constant ache, that goes together. So you're looking for things as you're going through these questions to make sense to you, to make sense of your understanding of how these things work. And of course, we have, electrical tends to be more nerve, ache is more muscle, throbbing is more vascular. So those are some clues there too.
This takes a little bit of time. How, if we're going to see a new patient to go through this, I think that's one of the challenges for dentists is you're running from room to room. What length of time would you schedule for a new patient with, do you do a phone interview first, or do you just put a block of time into?
Yeah, so great question, guys. So and let me address that. I'll say a word about it now, but I will thank you for asking it now, because later I'm going to show a couple things you can do as part of your diagnosis. But you can also do this, and this is what I teach my study club members and stuff, is you can do a real quick screening. So an initial examination in our office, in our TMD limited office. So my practice in Boise is limited to TMD and sleep. That's all we do. And if a patient's referred into us, that initial eval is only 10 to 15 minutes of doctor time. And that's probably more than necessary. If this was in a general dental practice, there is about 1 minute of diagnosis stuff you could do, and you would know if this patient is in the right place or not. And then what I would do is say, hey, you know what? It looks like you've got a jaw problem there. I think you're in the right place. I think I can help you. You weren't planning on being here for an hour today to go through this. I really need to spend time with you to figure out what's going on. So could we get you back? And then here's a pearl for those of you just kind of getting started in this field. And let's be honest, most of you on the call do not want to touch a TMJ patient with a 10-foot pole. And I understand that. If you're doing dental sleep medicine, here's Jamison Spencer's little catchphrase. Dental sleep medicine is easy as long as you're an expert in TMJ. And by the way, I know I'm probably pissing a lot of you off by saying TMJ, but I call it TMJ mostly just to piss dentists off. Now, I am a dentist because that's temporomandibular joint. That's stupid. That's like saying you have knee. Well, tell you what, guys, when neurosurgeons in your town refer you patients for their TMJ problem, and I figure, you know what, if the brain surgeons call it TMJ,
good point,
neurologist and everybody else in my town calls it that, what the heck, I might as well get on board. My practice used to be called the Craniofacial Pain Center of Idaho, until I figured out that no one else in the state knew what craniofacial pain meant. Right. And then we changed the name of our practice to the Center for Sleep Apnea and TMJ. So anyway, so sorry that I upset some of you by saying TMJ, but the dental sleep medicine, really, if you get this TMD stuff, oh my gosh, because now you don't get freaked out when the bite is a little off. We'll talk about synovitis here in a minute. You don't get a little bit freaked out if their jaw hurts. You understand these things a lot better. So my take on that guy, and we'll come back to that later, is very quick, like minute or two, couple minutes of, hey, let me check something. Ooh, boom, boom, boom. Yep, you know what? I think you've got a problem that we can help you with. Let's get you back. And again, if you're just getting started on this, my plea to you, so that you don't get frustrated and your staff don't get frustrated, you put these patients at the end of your day. Ideally, you're done. The hygienist is gone. because you don't want to be 15 minutes into a history with the patient and you're really linking up with them, and now you got two hygienists there tapping their foot, wondering where the heck you are for their checks. So
Right.
put it at the end of your day, do it sometime. Some dentists, when they're getting started in this, they don't work Thursday afternoons. That becomes their TMD day or something.
Mm-hmm.
So don't stress yourself out by trying to fit this in, because it does not work. It's not a good fit in. All right, region of radiation. Where exactly does it hurt? And I call this the one finger test. So you have the patient point with one finger to where it hurts, because otherwise they go, well, so where does it hurt? Well, it kind of hurts here, and they go over their whole body, and you're like, that's a lot of anatomy to cover. So I make them take it down to, well, it's here. And then my brain goes, oh, that's the jaw joint. It's here. Oh, that's temporal tendon. Here, it's the masseter. Oh, here, it's occipital. Here, it's temporal. So I can narrow that down if they can point to where it is. And then where does the pain start, and does it seem to travel? And this is trigger points. We won't have time to talk about this tonight, but there are muscular trigger points. This is referred to as myofascial pain, not myofascial. There's actually no such thing as myofascial. It's myofascial, as in the fascia surrounding our muscles. And there's things called trigger points in these muscles that refer pain. Trigger points injections is something we do as dentists to help with this, which is a very important skill, I believe, for us to have. In our club meeting we're having on Thursday, we're actually teaching injections for the attendees of that. So trigger point injections. So this is a patient says, well, it kind of comes up my neck and into my jaw, or it starts in my jaw, but it seems to go into my teeth, stuff like that. All right, this is one of my favorites. Severity. Now, you all do this now. This is on a scale of 0 to 10, where 10 is being burned alive. How bad is the pain? Now, you probably don't do that other part there, the how being burned alive. Now, this has really lowered the number of 10s that I get. It's lowered it. It hasn't eliminated it. So just the other day, I had a patient, and I'm like, so 0's nothing. 10 is for example, is the worst pain you can imagine, for example, being burned alive. And I could see her stop because she was just ready to say 10. Before I said being burned alive, she said 10, and she's like, oh, well, if you put it that way, 9.75. And no joke, that is 100% honest. She said 9.75. And I'm like, really? And it wasn't right that second. Right that second, it was an 8. And, I don't know about you, Guy, but knock on wood, I've never had a pain that I would describe as a 6 even, or a 5 probably. Heaven forbid, I've never had a kidney stone. I've never broken a bone. So if I was ever to say 6 or 7 on the pain scale, I know I would be curled up in a ball on the ground. Right. But you'll get these patients and they're like, yeah, 8. Right now? Yep, right now. You're like, you're freaking kidding me? 8. Or they'll say 10. 10's being burned alive. Yep, 10. Right now? Yep, 10. You're like, oh my gosh, you're killing me. So then I ask 3 follow-up questions. On average, what's your pain level? 0 to 10. At its worst, and then at its best. And this is really helpful because, again, people are going to typically give you the worst. So the patient's sitting there, hey, what's your pain? 0 to 10. And they're like 10. And you're like, 10 right now? And they're like, well, no, not right now. Okay, well, what is it on average? What is it typically? Well, it's a 6. What is it at its worst? An 8. And what is it at its best? Well, a 4. Okay, if they say anything other than 0 on what is it at its best, that requires a follow-up question. So you're telling me you always hurt. And then they'll think about it. And sometimes they'll say, well, no, not always. Say, so sometimes it's a 0? Yeah, I guess, yeah, sometimes it is a 0. Or they'll say, yeah, I always hurt. An always hurt patient, that's harder. Okay, a patient that's always in pain, that's sort of weird. Because again, everyone on this call has been in pain. And a pain that is always there, there's something up, right? That's weird. And in our head and neck area, that is something strange going on. So that's what you're looking for on the severity scale.
I assume you get a little bit of the information here. I think a lot of us dentists want to gravitate towards, well, this patient's just crazy. I think it was the name of this webinar,
That's right.
They're all nuts. And I do believe we jump there a little too quickly sometimes because maybe of what we don't know. But I would assume this is part of there are some that we can't help. And
Yeah,
and this is part of the screening process, I guess.
yeah, well, that's right. And the ones that you can't help, all this process you're going through, Opie Qrst, it won't make sense. So it just, from your understanding of anatomy, from your understanding of physiology, you know, like for example, anatomically. So we're split here in the head, right? So the right trigeminal nerve this side, left this side. Pain that crosses the midline is bizarre. So pain that goes across is weird. There are some trigger points that go across the midline, but most pain is going to be one side at least worst. It's weird. People always say that, like, yeah, Jamison, the patient just has jaw pain on the right side. That seems weird. No, that's normal.
That's right.
The patient who says, I have jaw pain on both sides, that's weird. And even the one that says it's both sides, you're like, well, so is one side worse? Well, yeah, it's way worse on the right, but my left side hurts too. Sometimes that's just sympathy pain. That's just the left side getting on board, you know, with the party that's going on the right side. You get the right side to go away, and the left side's like, oh yeah, I really had nothing to complain about. Let's talk about that nuts thing though, because I'm glad you brought that up, Guy, because I didn't define that. Normally I start this presentation with that. So again, my practice, actually we probably haven't mentioned this, I went right out of dental school into a TMD practice. So for those of you still on the call, you probably just want to hang up right now because obviously I'm nuts. I mean, who the hell goes into a TMD related practice right out of school? This guy. So I go right in. So I'm 20 years. I've been doing nothing but TMD, and then sleep started a few years into practice. How dare I say all TMJ patients are nuts? That's not very cool. Well, here's the deal. NUTS is actually an acronym. NUTS stands for not understanding their symptoms. That's what NUTS stands for. And these are the patients that come in to see us because, you know what? Dentists, even though the pain is here, we aren't necessarily the go-to person for this. If it's not in their teeth, they don't think dentist, they think doctor. So they go to the doctor and they say, my ear hurts. And they point right to their jaw joint, but they tell the doctor their ear hurts. So they look in their ear, they don't see anything wrong. They put them on drugs anyway, because what the heck? And nothing gets better. And then eventually they try other drugs and nothing gets better. So they send them to an ear, nose, and throat doctor. The ear, nose, and throat doctor says, I don't see anything wrong. So let's get a CT. They get a CAT scan. Nothing's wrong. They don't say anything wrong on that. So then they say, you know, let's send you to the neurologist. You probably got trigeminal neuralgia, which they say all the freaking time, by the way. And the patient Googles it. So then they're ready to commit suicide because they got trigeminal neuralgia, supposedly. They go to the neurologist. They do an MRI. They find out they don't have a brain tumor. Whew! Good news, I don't have a brain tumor, but I still hurt. What the crap's going on? They put them on drugs like Tegretol and Neurontin and things like that. They still hurt because they're not addressing the etiology of their problem. And sometimes they then get referred to dudes like me. So if you put yourself in that situation, how many doctors do you need to see who tell you they can't see anything wrong with you before you're a little nutty? And also, pain right here is totally different than pain from the neck down because we sort of live right here. I don't know about you, Guy, but Jamison Spencer is kind of right here. If my knee hurts, it's like it's external to me. I can point at my knee, or I can rub my knee. Oh, my knee hurts. But when you got a headache,
yep,
I'm not as nice of a person. I'm not as patient with my kids. I feel bad. It's way different than if my foot hurts. So patients with this pain here, and then they go to doctor, to doctor, to doctor, to doctor, to dentist. They get the dentist on board who's really excited to grind on something. So they grind on teeth and they grind on plastic, grind on what, and they're not getting better. They get a little nutty. So that's what that actually stands for, is not understanding their symptoms. It's not a slam on TMJ patients. So thank you. Thank you for bringing that up.
Well, thanks for the clarification.
Timing. When does the pain bother you the most? All the time? That would suck. That's a bad answer. Morning, afternoon, or evening. Random. I also don't like random because that's tough to pin down. And after meals or when eating. And again, that's very common. So yeah, my jaw really hurts after I eat. Well, here's a night guard, right? So have them narrow it down to when it hurts. Now let me give you kind of a pearl that would indicate a night guard, but it's a little confusing because the patient says, well, my jaw hurts the most around 10, 11 o'clock, and then it really kind of starts hurting after lunch. Lunch hurts to eat, and then it hurts a little worse. Well, here's the analogy to this. So that actually could be an indication for a night guard, and or let's rule out sleep apnea. Okay, and that's one of the biggest things here we're going to do is rule out sleep apnea. Why that is imagine, remember the last time you went in and did a leg workout when you had not done a leg workout for months. And you're in the gym and you're pushing some heavy weight and you're doing lunges and you're doing stuff like this. How did you feel as you left the gym? Probably okay, right?
Right.
Yeah, you feel you did something, you got a good workout, but you're okay. Get in your car and maybe you get home, it's a little bit stiff, but then how do you feel 3 hours later? Yeah. You can barely move. You go to walk down the stairs and you can barely walk down the stairs, and it gets actually progressively worse. Well, that could be a patient who's clenching and grinding their teeth around the last few hours of sleep. And they wake up, and a key phrase that those patients will say is, well, my jaw doesn't hurt in the morning, but it feels tired. Okay, listen for that. It feels tired. It doesn't hurt, but it feels tired. Okay, that's the leg workout. And then later on in the day, that's really going to hit them. And making the connection here with sleep apnea, well, what is going on there a little more in the last part of the night? Well, REM sleep. Sleep apnea tends to be worse in REM sleep. So it's possible that some of these patients are clenching and or grinding and or just posturing their jaw. That's one that sometimes confuses us too, I think. We think that we got to see tooth wear. We don't. Some people will just hold their jaw. They'll brace their jaw forward without tooth contact. And that will use these muscles, use these elevator muscles, use lateral pterygoid, use other muscles to posture their jaw forward so they don't die. Right. So watch for that timing.
This may be, we do have some questions coming in and we will get to all of them, but this might be good to tie in with that. Sure. We have a question that says a patient comes in with TMD and an orthotic device already. What's our next step since the present device isn't working? You want to address that at the end, or is this a good time for that?
Well, unfortunately, and everybody write this down because these are the two words that apply with almost every question related to TMD. Ready? It depends.
That's exactly what I say a lot too. You can never be wrong, right?
Yeah, it depends. So the reason it depends is it's going to be what's the piece of plastic, and this is a common dental way to think, and I don't mean a slam on us when I say that. Is we are oftentimes compelled. It's like, hey, yeah, I've got this splint. My jaw still hurts, and what are we gonna do? Well, let's grab the splint and grind on the freaker, or let's add some plastic to it, or whatever. Well, what if it has nothing to do with the splint?
Right.
What if it has nothing to do? So I know we want to do stuff, but sometimes what you want to do is get a diagnosis. So what I would say, rather than they come in with an orthotic and it's not helping, what do I do with the orthotic? My question would be, okay, why did they get that in the first place? Was it the right thing to do for their diagnosis? Now we would kind of say, well, maybe it's not, or even maybe the patient's not doing it right. Okay, so this is a little out of context right now, but let me give you my biggest #1 TMJ pearl ever, history of ever. If you do this, you will be more successful with any patient with a TMD problem. Okay, here it goes. It's another phrase. Let's see how many words. 4 words to save you for TMJ problems. Here it is. Lips together, teeth apart. Lips together, teeth apart. That is the whole ball game, folks. That's the whole ball game. Because people can't contract their masseters and their temporalis very hard without putting their teeth together. And we screw this up all the time, y'all, because we give people splints and we grind on them for half an hour and we check their occlusion and we put computers in their mouth and we do all this stuff to check it and make sure it's perfect. And we go tap, 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 tap. And where does it hit first or hardest? And patients they've never been asked any of these questions in their whole life. They have no freaking clue. You ask them, how does your bite feel? They're just as likely to say it feels sad as to tell you, that it feels off or whatever. As a matter of fact, one of the biggest red flags you can ever have in your practice is the patient that if you ask them about their bite, they say, you know what, doc, I think it's hitting a little bit harder on the mesiolingual of cusp, whatever. You're like, oh crap, I'm screwed. So this person is an occlusal neurotic. Normal people don't think about their bite, which is why, by the way, as a dental sleep medicine person, it can be a little confusing because you're like, well, how's your bite? Good. And then you're like, well, bite down. And they're like, okay. And they bite on their front teeth. And you're like, no, bite your back teeth together. I am. You're like, yeah, no, you're not. Because they never think about their bite. So lips together, teeth apart. There are patients of yours. If you ever do a splint during the day, I promise you, you have patients that have that splint in and they're holding their teeth together on it all day. You have patients that think it's normal to rest their teeth together all day. You know that's not normal, but you have patients that don't know that that is abnormal. And I use an analogy with that of running. Again, I'm a runner. Most of you on this call right now could go out tonight after this call and run for, well, actually, before I say that, Guy, about how much time do we spend with our teeth together during the day, approximately?
10 minutes, 5 minutes. I don't know. It shouldn't be
Perfect.
a lot.
Love it.
Yeah.
So what I normally hear, and I've asked this question literally around the world, literally, and I get 5 to 15 minutes. 95, 98% of dentists are saying it's between 5 and 15 minutes. Now, let me ask you another stupid question. That 15 minutes is all at one time, right? Just all of us, we pick out 15 minutes during the day to... No, okay, that's stupid. So we're only putting our teeth together for a fraction of a second many times throughout the day, usually when we swallow, and to some degree when we chew. By the way, do we tend to swallow more when we sleep or less?
The answer to that is we swallow. I know we swallow. I would say more.
Actually, it depends would be the answer. But for normal people, it will be less because your salivary production is less. Now we may have some patients with oral appliance therapy, whatnot, and maybe they have a little bit more active salivary flow. But in a typical healthy patient, it's reduced a little bit. So we'll swallow a little bit less. And if we think that through, we're like, well, holy crap, how much time are people really spending with their teeth together? And it just ain't much.
Right.
So if it's 15 minutes all day, then theoretically, if we're asleep for a third of that, that's 5 minutes. 5 minutes that a normal person should have their teeth together at night.
Mm-hmm.
So now, back to my running analogy. Most of you could go out and run for 5 or 10 minutes and not die. Okay, you might be winded, but you could do it. But how many of you on this call could run for 4 hours? Okay, probably some of you, but probably not most of you.
Besides you and Jason, that's about it.
There you go. I'm doing a marathon next week, so, and it's going to be under 4 hours though, so I'll only have to run 3 hours and 20 minutes. But I could run for 4 hours if I wanted to, and that's the difference. Is if I just take, like, my boys are training for a marathon in October, and their longest runs right now are about an hour. If they went out for 4 hours, they'd be crippled. Mm-hmm. These patients that we're talking about, instead of spending minutes throughout a 24-hour period with their teeth together, they're spending all day. Lips together, teeth apart. Make sure that that is a major thing in your discussion with your patients. All right, so initial exam, and we're running, I'm going a little slow here, so I'll pick up the pace here a little bit. We want their history of their TMJ problem, what's their chief complaint, where does it hurt, when did the symptoms start? And that chief complaint is really important, because if we don't understand the chief complaint, then we can't help their chief complaint. And sometimes we may blow off chief complaints. For example, they say, well, my jaw clicks. And you're like, whatever, people's jaws click, so what? And you're like, move on. Well, and it hurts when I chew. Oh, cool, there you go, there's one. Because we would think that would suck to hurt when it chews. And I have headaches. Oh yeah, I don't like headaches either. So we're treating the headaches, thinking we're champs, and the patient's headaches go away. Patient's like, yeah, I don't have headaches anymore, but you didn't help me at all. Well, what do you mean I didn't help you at all? Well, my jaw still clicks. Yeah, so what? Who cares about clicking? I care about clicking. That's the whole reason I came to you. Oh, well, yeah, who cares? So we need to be dialed in. Now, maybe we can't help their chief complaint, but we better understand what it is. Where does it hurt? When did it start? All right, range of motion. Here's some skills. You're going to need a really expensive tool for doing this TMD stuff. It's called a ruler. You can get one of these. I sell them. They're only $25,000. I do payment plans on them. It's a dental ruler. Now that's a joke for those of you who don't know my sense of humor. So I'm the low BS guy, where BS stands for buying stuff. So you don't need to run out and buy a bunch of stuff to do a good diagnosis. But this, you kind of need a ruler. And if you're too cheap to get a ruler, I'll show you how to get away without actually having a ruler. And that is what I call the 3 fingers test. So normal range of motion is 48 to 52 millimeters or 3 fingers. That is the patient's fingers, not your fingers. You don't stick your fingers in your mouth. It's the patient's fingers. That's normal. Hyper would be over 55 millimeters or 3 knuckles or more. Reduced would be 30 to 40 millimeters. This is 2 knuckles between the teeth. And if you ever see this, they're in their 30s, they're opening in the 30s, I want you to suspect that they've got a disc out of place. And it's been out of place a long time. Limited is 26 millimeters. That's kind of a specific one. And that is about what's called a acute non-reducing disc displacement. Talk more about that in a minute. Severely limited is less than 20 millimeters, and it's usually about 1 finger. And there you're going to suspect trismus after you have given an inferior alveolar nerve block, and probably you accidentally tagged the medial pterygoid. So those are kind of normal range of motions there. I also use something called spray and stretch to figure out, now spray and stretch is used also for treatment, but we're using it to figure out where is the site and source of the pain. So if the patient said my joint hurts, my in front of my ear hurts, my TMJ hurts, I would spray this cold stuff on their face and have them open and close and spray it on their face over the joint, open and close, spray, open and close. And then I would ask them, does that make the discomfort worse, better, or no change? Worse, better, or no change? Now, if the pain is coming from where I just sprayed, it should make it better. Okay, I ask worse, better, no change because I don't want to put placebo effect into the diagnosis. Okay, you don't ever want to put placebo into diagnosis. So I ask it backwards of what I think is going to happen. Worse, better, no change. And it kind of confuses the patient. And they go, well, let me think about that. I think it's better. That will help you to know where the pain is coming from, the site and the source. If they say, well, no difference, you say, well, it's cold, right? Yeah, it's cold, but it's cold and it hurts the same. Yeah, it's cold, but it still hurts the same. Well, maybe that pain's actually coming from somewhere else. Maybe it's coming from their neck. Maybe it's coming from their tooth. Now, this is the stuff I want you to get. So this one here, Gebauer's Instantize, hopefully you can see my mouse moving around if it looks like you can. This mist spray, don't buy that. So that you don't want that. That's like hairspray. You don't want that. So this one comes out as a stream, and check it out. This cracks me up. So you can get this one on Amazon for $55.48 plus free shipping if you are Amazon Prime. Or you can get this one for $39.59, and it's the same freaking stuff. Look at that. The formulations are identical. It's just a different bottle. You're paying, what's that, like 15 bucks more for a green bottle. So that, don't get suckered in by that. So
how long do you spray that on? Just 2 seconds?
Yeah, you're just gonna go like spray, spray, spray. So it's maybe 1, 2, 3, release, 1, 2, 3, like that. So it's spray, 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 and then have them open, close, spray, spray, open, close. Do that 3 times.
Okay.
And so those 2 things, actually, I'm going to go into something here quick, but before I do that, what I just covered there, those 2 things, range of motion, 3 things actually, chief complaint, when it started, stuff like that, range of motion, and the spray and stretch. With those 3 things and palpating the jaw joints, so 4 things, chief complaint, range of motion, palpate the jaw joints, and then the spray and stretch. With those 4 things, which you should be able to do in a matter of a couple minutes, you should have a pretty good idea of what's going on. So that would be my quick screen. Well, it looks like their range of motion's reduced, their jaw hurts, it's not clicking. I do the spray, they say, yeah, that makes it feel better. hey, you might have a non-reducing disc displacement that's chronic. I think you're in the right place. I think we can help you. Let's get you back on the schedule for Thursday afternoon where we can actually spend like an hour together going over this. That's what I would do. Or, wow, that's really limited. You say your jaw used to pop and click and now it doesn't anymore. You might have an acute non-reducing disc displacement. Let's get an MRI and confirm my diagnosis. So you can, believe it or not, you can, in just a matter of a couple minutes with those tools I just gave you, figure out what it probably is and then get them back quickly, because most of these things we need to move fast. All right, now I've got a treat for y'all. The way I'm about to teach this, I've never taught before. So there's something called capsulitis and synovitis. And capsulitis has been taught incorrectly for multiple decades, including by me, because I was taught wrong. And I've known this for a while, but I just decided, you know, what the heck. It's kind of like the mental nerve block, for example. The mental nerve block that we all call a mental nerve block, and people in Iceland call it mental nerve block, and in Brazil and in, you know, Australia and New Zealand and everywhere I've taught, everybody calls it the mental nerve block. But it's not the mental nerve. If we block the mental nerve, just the lip gets numb and the soft tissue, not the teeth. But we all call it that, but it's actually called the incisive nerve block. We just do it at the mental foramen. So if you are thinking capsulitis synovitis, I don't want to confuse anybody, but what I'm about to talk about is technically a synovitis because it's the inside part of the joint capsule that is injured. It's not the tough ligaments that are injured. It's the retrodiscal tissue and all that vascular tissue inside the capsule. So what are we talking about here? This is, by the way, the most common TMJ problem you'll ever see. Now, someone might be saying, wait a second, muscle problems are more common. Yeah, right. I'm saying the most common temporomandibular joint problem you'll ever see, not the classification of problems, but actually joint problem will be capsulitis. And this is super common with patients who are being treated for sleep apnea too, is to get a synovitis or an inflammation of the tissues of the TMJ. So what's our diagnosis? Well, we have history of trauma, continuous TMJ pain, hurts to palpate. When you push on the joint, that hurts. Their range of motion is not necessarily reduced. They'll have an acute malocclusion on the injured side. So if I had a right-sided synovitis, when I went to bite down, my teeth would be apart on the right side because my joint is swollen. My condyle can't seat all the way. So they have an open bite on the right side, which kind of screws with our mind because we're looking for hyperocclusion and stuff, and they don't even have occlusion. So that would be synovitis. Pain with clenching, no pain with clenching on a tongue depressor. So if you put something between their teeth, and I'll do this over the phone all the time, I'll say, sorry, I got a fly flying around me here. I'll say to the patient, when you put your teeth together, does that hurt? And they'll go, yeah, that hurts. Say, okay, put a pen between your teeth in the back. Does that hurt? No, that doesn't hurt. Cool, that's it. In your office, you use a tongue depressor, okay? I don't use a cotton roll, I use a tongue depressor because the tongue depressor is hard. And the patient's not intuitively going to think that biting on something hard will feel good. So I don't want to put placebo effect into the diagnosis. So that is... It
goes in the back, not in the front, you said.
In the back, exactly. Yeah, I put it in the back, and that's going to keep the condyle from seating up. If you put it in the front, it would depend on angles and stuff, but it could still hurt because it could still compress the capsule a little bit, but in the back, it for sure can't. Good question. Treatment, anti-inflammatories, PT, aqualizer, soft splint, hard splint if necessary. We'll go over those. So anti-inflammatories, I like using Advil, but you can use whatever anti-inflammatory you want. If the patient has been put on prednisone before for their hip or shoulder and they had a good experience, then I'll put them on a Medrol dose pack. I refer a ton of patients to physical therapy, and like literally every day we send patients to physical therapy, and they will do either iontophoresis or phonophoresis. And what those are is iontophoresis is pushing a steroid medication through an electrical pad through the skin. Phonophoresis is using a steroid coupling gel. There's no gel on her face right here, that's just the wand, but using a ultrasound to push that medication into the joint as well as into the muscles. So phonophoresis and iontophoresis, those are very effective. Now, a splint that we would use.
Let me ask you a real quick question on it. Do most physical therapists readily know this, or do you have to help educate them?
No, so almost all physical therapists are familiar with iontophoresis and phonophoresis because they use it all over the body. Now, using it for the jaw joint, they may not be expert in, but most are. As a matter of fact, probably your biggest problem with physical therapists, and this is a little bit with chiropractors too, and when I say a little bit, I mean a lot, is they think they don't need you. So they're going to take care of the whole problem all by themselves. And a lot of times it does have to do with the bite. It has to do with how they're using their jaw. So I am really picky on who I work with physical therapy wise. I want them to know what they're doing. So I would meet with them, and if they seem super cocky that they've cured every TMJ problem by, iontophoresis, then I'd probably find somebody who's maybe a little less knowledgeable and teach them how I want that patient treated.
Great.
All right, splint therapy. So our splint, we need one that's going to self-adjust. And if you're not familiar with this, you really need to be. And that's called the Aqualizer. Aqualizer.com, I think, is their website, 1-800-HELP-TMD. I have nothing to do with this company, but Aqualizers rock. So how this works is you've got two lakes connected by a river. And these things go between the posterior teeth. This goes in front of the teeth on the upper. So this is between your upper teeth and your lip. And then these go posteriorly. So if the patient has a capsulitis on the right side, they would bite down, squish the water on the left side, push it over to the right side, which would raise it up, and their occlusion posteriorly would be perfectly even. Does that make sense? And then as the inflammation goes down, then the condyle seats again, then this thing self-adjusts, and voila, after a few days, they take it out and bites back to normal, and they're good to go. If you were to fit them with a hard splint, you could actually screw up their occlusion because their brain would be like, oh crap, where am I supposed to go? The Aqualizer will take care of this on its own. Everyone treating dental sleep medicine patients must have Aqualizers in your office. This will save your bacon because this is something you can use, and the patient could continue to use their sleep apnea appliance instead of discontinuing treatment while you're trying to get them better. You could have them using the Aqualizer during the day, which is going to take the stress off that joint and not allow them to keep punching the bruise, I like to say. And they could actually continue to wear their sleep appliance at night because it's probably not the sleep appliance that's causing their problem. Now, once this is all resolved, then you might need to move to a night guard or a day splint or something else, depending on what you think caused the problem in the first place. So here's
There's a question about when you'd use an NTI. I would assume that an NTI would actually be contraindicated in this particular situation.
Depends. Again, the NTI or the quick splint could be used in a pinch. The advantage of the Aqualizer over both the NTI and the quick splint in a synovitis is the patient can actually wear it during the day and talk with it in, and most people aren't going to know it's there. Whereas if you put something on their front teeth, they ain't going to work, right? They're not going to the store. You could wear an Aqualizer, and every time you swallow, it's doing its job. However, between a hard splint or a traditional night guard Michigan splint and an NTI or a quick splint, I would probably do NTI or quick splint if that's what you had on your shelf. The cool thing with the Aqualizer is it's going to self-adjust.
Right.
An anterior point stop is going to sort of self-adjust too because the condyle will allow to be seated. I just get a little more nervous. The Aqualizer is super predictable on what's going to happen. Plus, you get another bonus. The bonus is if the patient says, oh, I broke it. And I always tell them this in advance. You might break this. It's filled with water, not going to hurt you, but you might break it. If you break it, then we learned something, didn't we? You're clenching your teeth at night. You're getting some force on here. I'll give you another one for free, but we need to address what's going on. Harder to tell that on an NTI because it's so darn hard, the Lexan. Quick splint, a little bit softer material, a little bit easier to tell. Does that make sense though?
Yeah, sure does.
Cool. All right, so here's our recap slide. So for a synovitis, you've got pain in and around the jaw joint, so it'll hurt. They have a posterior open bite, hurts when they try to bite their teeth together. That's key. Doesn't hurt when you put a tongue depressor between their posterior teeth on the same side. Treatment, anti-inflammatories, and aqualizer. All right, then we got one more kind of diagnosis thing here, and we're almost done here. Looks like we're going to go a little over an hour. Oh, I need to tell him to be quiet here. Click, click. That's Dr. Westonson. Really excited to tell us all about these. So these probably don't look that awesome when we're doing a webinar like this, but all of you can go to YouTube and search Yoint videos, Y-O-I-N-T, Yoint videos. Dr. Westonson is Swedish, so someone with a sense of humor. It wasn't me, I didn't put them up, but someone's posted those as under Yoint videos. So here we have normal, reducing displacement, non-reducing displacement, and degenerative joint disease. And spend a little time with these videos and get really comfortable on what a reducing displacement is. When the patient opens and it goes pop into place. Your patients do not understand this. They think they are popping out of place.
Right.
And they're popping into place. The non-reducing displacement, where the disc is out of place all the time. This is the person that's probably going to open in the 30s. And if you're treating them for sleep apnea, you might tell them, hey, you know, I bet you've got a disc out of place and it's probably been out of place for 20 years. You might actually start clicking with treatment. And that clicking would be them getting back on the disc, which would be positive. However, in my career so far, I've never had a patient perceive that as positive.
Right.
But it is. And sometimes I have treated people to get them back off the disc because that's what they had before. Now I'm going to stop this video right there. And that'll stop on your all screen at home too. And then I'm going to stop the normal here also. Click. So on the normal, now that I've stopped that, notice the big joint space that we got there. This is a normal joint. You would probably say that condyle's down and forward, but it's not. That's where it's supposed to be. The reducing disc displacement, when the teeth are together, there is no joint space. If I stop it there, there is no joint space, a millimeter or two. That person is off the disc. Now, when we are treating the patient with an oral appliance for their sleep apnea, we are going to take that person and keep them on the disc and hold them about right there, which looks tremendously like the normal joint. And this is another confusing factor for dentists and patients, because this patient, their brain now goes, sweet, my joint's in place again. This is fantastic. But what's going on with their teeth? They have a posterior open bite. They're out on their front teeth. And then they go to the dentist that's, you know, their normal dentist. It's not treating them for their sleep apnea. And the dentist says something logical like, oh, that sleep appliance you were given, that must have intruded all of your posterior teeth. That's the problem. That sleep appliance, that must have allowed all the front teeth to super erupt. That's what I see going on here. Okay, now I hope you all know how stupid that is, right? So they just don't understand the anatomy that's going on. And then the next thing you know, you're in trouble because some dentist told your patient that you caused their TMJ problem. So I use these videos all the time in my practice. I have the patients educated on what's going on. All right, so spend some time with those videos and use them in your practice. Help your patients understand that. Now, last couple things here, who to refer. These are the patients you don't want to treat. You can send them to dudes like me because I know how to handle it. But if you're getting started in this, these are the people you're going to refer. Chronic pain patients. Patients who have had problems for decades and decades and decades, and no one's helped them. And they're probably on a bunch of meds. That's not somebody you're like, hey, well, you know what? Let's fit you with a splint. If you are really expert in this, you might do that, but it's really all about the diagnosis, and that's going to be a tough diagnosis when they're on 15 drugs. Mm-hmm. No clear etiology or diagnosis, just kind of said that. No clear PDQ. This is something I learned from a friend of mine named Clifton Simmons. P is pain, D is dysfunction, Q is quality of life. If the patient doesn't have pain, you can't make them feel better. If they can eat beef jerky 3 meals a day, they don't have any dysfunction, and you can't fix that. If their clicking is so loud that it scares the cat, but they couldn't care less, then it's not affecting their quality of life. So if they're not having any PD or Q, then educate them that someday they may have PDQ, but right now they're not. So, you know, They don't want to be treated, probably don't need to treat them because they may just live the rest of their life like that and they're totally cool. If the problem you think is only muscle, then I refer to physical therapy. Let them go to physical therapy. Insurance is going to cover it. It's not going to cost them much out of pocket, and maybe the physical therapist can get rid of that within a couple weeks. You don't want to dink around with this patient for 3 months with splint therapy when a physical therapist could have got them better in about 6 days, or 6 visits, I mean. And then the patients who don't want to get better. Every once in a while, you're going to come across a patient that has something to gain by continuing to stay in pain. That may be support from their family. It may be support from their work. It may be other psychological issues that are going on. And you can help these people sometimes. But if you just get a vibe that this patient really doesn't want to get better, I wouldn't enter into treatment there. Now, who you want to treat, on the other hand, is the patient who just recently got hurt. The person that's like, yeah, my jaw's been hurting since I got hit playing basketball. Oh my gosh, that's the perfect patient. The younger, the better. Teenagers are super easy to treat because they're just so resilient and they get better so much faster. But the younger the patient, the easier it is to help them. Early clicks, the patient that just barely opens and their jaw pops. This is, again, confusing to us because it's like, oh my goodness, that's bad. Their jaw clicks immediately. So here it is with TMJ problems. Take everything you would think intuitively, flip it 180 degrees, and then you'd be right. So a loud click, that's bad, right? No, loud is awesome because the disc is in good shape, it's just in the wrong spot. Early click, it clicks immediately when they open. That's bad, right? No, that's awesome because the disc is coming into place really quick. A late click, so when you say, oh yeah, it's not that bad because it only clicks when they open really wide. No, that sucks because they open, and finally at the last second, click, the disc goes into place. They're just a few days away from a non-reducing disc displacement. So seriously, with most TMJ problems or TMJ things that you think about, take what's logical, flip it 180 degrees, and then you'll be right. Capsulitis, or oh shoot, I missed it on my slide. I changed everything else to synovitis because I'm new and improved, and I left that freaking in there. So capsulitis, synovitis we just talked about. You want to treat them fast. Don't be like, oh, you know what? That sounds exactly like what Jamison talked about. Let me get you back in 3 weeks and we'll talk about it. No, you need to get them treated immediately so they are better in a week. And then lastly is trismus. And that's the person, again, you did the inferior alveolar nerve block and they now can't open. That's another person you don't want to be like, well, let's see if it gets better. No, you want to get them to physical therapy, get them on a Medrol dose pack, get them open because it's a muscle problem. All right, I think, yes, that is the end of my main slide. So we are past an hour, I know, but I'm okay. I'm good, so we can hang out and answer questions as long as you guys are okay.
Yeah, we've got a few other questions here. I'll get through them. So thanks everybody for attending. That was fantastic. So let's get to some of the questions. I think as we go through it, one of the ones that's here is where can we learn more about TMD? I mean, this is great, but an hour webinar is not going to make us an expert. You want to talk a little bit about if you want to help someone go further down the education path?
I'd love to, and actually let me segue into something that I know that you're working on, and this is your slide, Guy, that I put into my presentation here.
Well,
but this is super exciting. Is DS3 has put together this module, and Guy mentioned at the beginning that I helped out a little bit, not a ton, and you guys got a bunch of world-renowned experts to give you input on this, and this is really cool. And what we just went over with this Opie Qrst thing and everything is in the software. So that's going to take people through how to do it, and they don't have to remember, now what the heck did Jamison say, because it's all there in the software. So that, if I'm already using DS3, that's a no-brainer, is to add this module on there to help you work through those patients. You know, it's something that you hope you never need, and as soon as this happens, so here's the thing, everybody on this call, frankly, just because you're on this call, the universe is now got a sense of humor, and you're going to start seeing more TMD patients.
Yeah.
Just the way it works, because you're no longer naive. You're no longer ignorant. And this is going to happen. So that would be one thing, Guy, and I'll let you talk a little bit more about that. The other thing, I do have a study club, and our study club is mostly online. I mean, it's an online study club that I developed to help people to be able to learn these things when they want to, where they want to, how they want to. There's video modules, you can read it, you can listen to it in your car, you can do all this stuff. It's over 50 hours of content, heavy on the sleep apnea stuff, but we have over 400 members of Spencer Study Club, and I would say I got probably 150 of them are diplomates. These are not beginners in sleep, and a lot of them joined Spencer Study Club purely because of the TMD. That's why they got in. That was the gateway drug, and then once they got in because of TMD, they actually learned some stuff about sleep that they didn't know too. But that's a good way to learn, because a lot of this stuff, the bummer is you may not need it every day. And now 3 weeks from now, you're like, oh, crud, here's a synovitis patient. I know now, what did Jamison say? I think he said to bite on a tongue depressor in the front. Well, no, I didn't. So right. Sometimes it's nice to have that stuff to go back on. So that's something that we have out there to help people learn more about TMD in relation, particularly to treating sleep apnea patients.
Well, if someone wants to join the Spencer Study Club, how do they go about doing that?
Right. So we don't have open enrollment anytime you want. If you're going to be at the Academy of Dental Sleep Medicine meeting this weekend, you could come to our booth. But the way I'd encourage people to do it, and I think, yeah, here on this slide here, if you would email info@dentalsleepsolutions.com and let them know that you'd like an invitation. So like I said, we normally only have open enrollment a couple times a year, but for friends of Dental Sleep Solutions, I'd like to offer an invitation to join if your clients are interested. So what you would do is email info@dentalsleepsolutions.com, say, hey, pass this on to Jamison, and then that way I know that, how you got to us is through Dental Sleep Solutions, and we can get you a special invitation and get you in the club. That'd be pretty cool.
That'd be great. As you had with the previous slide, we'll be launching our TMD module in June. If you're at the AADSM, certainly come by. We can give you a glimpse of it. June 18th, actual launch date, if you're an existing member. It's just a matter of contacting us, and we can add that to your membership. I'm real excited about it, and I'm excited that Dr. Spencer's gonna be available to us, and us to be able to help our members learn more about TMD, because I think I feel we're pretty confident in dental sleep. We've been doing it a long time, and I know a fair amount about TMD, and our team does. But it's great to have someone like yourself with the Spencer Study Club for people who really want to learn this and become more experts in TMD, because I agree, the more I learned a lot tonight as well. So thanks for being on.
Guy. And one of the things I'm most proud of in the study club is we have a secret Facebook forum where our members post cases and stuff, and they'll get feedback from their colleagues in real time. So I know as you launch this, there's probably a little trepidation in putting this out there, because now Iatros is going to get 4,000 emails saying, hey, yeah, I think the person's got, a right-sided reducing disc displacement. What do I do? And that's going to be pretty tough for the folks there at Dental Sleep Solutions to be like fielding 1 million TMD-related questions a day. So hopefully this can be something that your clients and others out there can use to be able to feel comfortable that, hey, I'm not alone. And it's not that I got to go out and take 1 billion hours of courses. I can jump right in because I've got Jamison and 400 other people looking over my shoulder, and probably, so far, knock on wood, there's never been a case posted in our forum that I was like, wow, never seen that before. So yeah, that's going to be super rare on the TMD side, that it's going to be like, oh yeah, never seen that before. I've got about 10,000 TMD patients under my belt, so it's rare to have it be something that I've never seen before.
Well, great. We have a couple other questions I want to make sure we get to. And for those of you who joined a little late, maybe go to the next slide there again.
Yes, sir.
Jamison, if you will get CE via the email you registered with, if for some reason you don't see it, look in your spam folder. If that doesn't get you somewhere, if you should have the CE, but you can certainly contact us at DS3. And for those of you who don't know, stop by the booth if you're at AADSM. That's all we do is help dentists who want to treat patients with dental sleep medicine in their practices, and that's why we exist, is to help offices bring that valuable service to their patients. So anyway, let me get a couple of these questions here because I know we've gone a little bit over, but I think we told everybody we'd get to them. So let me just go down the list here. Do you treat every disc displacement with reduction to prevent a non-reduction situation is the question.
No. So, well, and actually, you know, I always got to give my standard, it depends. So the do I always would be no. So it's going to have to do with PDQ, pain, dysfunction, quality of life. So if a patient's 45 years old, their jaw's popped and clicked since they were 15, and they have no pain, no dysfunction, no quality of life, then I'm not going to treat it. I'm going to educate them and tell them what could happen. But as I like to point out with those videos, do all reducing disc displacement patients eventually go to non-reducing? Well, that cadaver didn't, you know. We had a pretty good video there of a nice popping jaw on a dead person. And in Sweden, they didn't sacrifice those people to make those videos. So know that you can go to your grave with that type of click. So I don't do that. Now, on the other hand, here's the caveat. If Guy, your 14-year-old daughter clicks, I'm going to treat her. And she may have no pain, she has dysfunction technically because the disc displacement is dysfunction. But in a teenager, I would want to treat it because a teenager can heal. And this happened with my own daughter. My own daughter developed a reducing disc displacement after braces. Darn orthodontist, right? Let's throw them under the bus. If you weren't here earlier, no, you don't throw them under the bus. So we did everything right, no extraction, blah, blah, blah. She still started popping and clicking, and we did some things, did some injections in the jaw joint, and we got her back on the disc, and she doesn't click to this day. She still wears a night guard. She's now 24 years old. So in teenagers, yes, and it's a long-term treatment plan. In adults, especially if they have no PDQ, then probably not.
Great. Fantastic answer. Next one on here, biggest hurdle, referral from physician, patients expects insurance to cover the TMD. Treatment has no conservative treatment coverage except for surgical intervention. So essentially they're saying, you know, how do you handle the fees here when the insurance is not going to cover it?
Totally. And for the vast majority of you on this call, that's going to be you. So in Idaho, it's an excluded thing. There's no coverage for TMJ problems. In most of your states, that's the way it is. And that we could talk a long time about where that came from and stuff like that. But sometimes I get scared that the insurance companies could do that with sleep apnea, except with sleep apnea, we actually have a ton of literature and evidence. In TMJ problems, we've never gotten our own house in order. They're still fighting and arguing about, is it occlusion, is it not occlusion, blah, blah, blah. So bottom line, most of the time you're going to be talking to that patient about fee-for-service type of treatments, and I do a case fee. It depends on what we're doing for the charges and whatnot. The difference in my experience between TMD patients and sleep apnea patients is TMD patients, they tend to care about getting out of pain. So pain is a pretty big motivator. So most of those patients, not all, but most of those patients, if they can find a way to pay, they're going to pay out of pocket. With regard to the surgical treatment only, sometimes I've been able to reverse stuff like that because you get with your oral surgeons, and trust me, they do not want to see these patients. They are the dumping ground for the TMJ patients. They know only slightly more about TMJ problems than you do. They know that they don't want to do surgery on them. And if you talk to them and go with them to the insurance company and they tell the insurance company, look, this is stupid. My dental colleague here can be handling this way better than I can for less money than I can. I've had some cases where that's been reversed. and they've changed their policy. But rule of thumb, plan on having the communication skills to help that patient realize why they need care.
Yeah, we kind of went full circle in our practice. My partner, Dr. Griffin, does she's got a real passion for TMD, and she was getting coverage in another state before she moved to Florida, and then moved here, and we just weren't able to get the coverage. And it's almost the moment. I think having a policy to where you make your mind up how you're going to do that. If you crack the door for insurance, now that's the whole discussion is going to be about that. If you just say, look, we're not going to get coverage for this from the get-go, set that expectation if that's your policy. Don't even crack the door, because once you crack the door, then they can all get sidetracked.
Yeah, literally the phrase I use with our patients, because sometimes once in a blue moon they'll have a federal plan or something like that, and they might have a little bit of coverage, and I'll say, these are going to be our fees. Your insurance might help you, but I don't want you holding your breath. If you get $50 from your insurance, you're doing good, and I really don't want you to go into therapy if it's not something you can afford, because that's just going to add to your stress, and that's not going to help you at all. And I think the patient appreciates that. And I mean, one quick story on that. I had a patient who needed some extensive stuff a long time ago, and she couldn't afford it. And she shows up at my office one day, and she actually wasn't my patient. She was my mentor's patient, and she'd seen him like 5 years before. And she comes in and she says, well, I'm ready. And I'm like, what do you mean? Well, I need to have a bunch of crowns done and stuff like that, and I'm ready now. I'm like, what do you mean? She's like, I've got the money. And she had saved up for like 5 years to do this, basically a full mouth reconstruction, because she really wanted it and needed it, but at the time she couldn't afford it. So I think people, if you do a good diagnosis, it makes sense, the treatment plan, even if they can't right then, if that pain keeps coming, then they'll be driven back to your office. And, I wish insurance covered it. That would make it easier for a lot of people, but the vast majority of states, there'll be no coverage at all.
Okay, great. Just a few more questions here. I know it's getting late, but I'm kind of interested to hear your answer to this. Do you ever use what's the question exactly says, how about low-level laser?
Yeah, I've heard really good things from a lot of my friends. Again, I'm the low BS guy. I'm the low buying stuff guy. Right. There was a point in my career where I bought everything, and probably a lot of us have been through this, right? I bought everything, and I used it. I used stuff, and I learned from it. I don't think that there's ever a piece of equipment or whatever that I bought that I didn't really learn from. But after a while, I realized that I didn't need to do whatever it was. So low-level laser, I have a lot of friends that use it and say that it can be really, really helpful. Here's the reason that we haven't bought it in our office, nor do we do any physical modalities at all. So we don't do iontophoresis, we don't do phonophoresis, we don't do tensing, we don't do any of that stuff. We could. The reason we don't is because in Boise, Idaho, so here's sort of the irony. So we just talked about insurance coverage a second ago. So TMJ is not covered by us, but it's covered by everybody else. So I always tell my patients, you could be treated by the neurologist and the physical therapist and the chiropractor and every other doctor in town, but as soon as you walked across our threshold, your headache just became TMJ. Your pain just became TMJ. And don't be thinking, oh, well, I'll just code it different. Doesn't matter, because your NPI says dentist, and as soon as it says dentist in their computer, it says TMJ. So I would rather just say, hey, you know what? My physical therapist can do that, and some physical therapists are doing low-level laser. Some super sophisticated ones that are willing to take that investment. They'll do dry needling with acupuncture. I actually went and got trained in acupuncture, medical acupuncture, 300-hour course, and we almost never use it anymore because I can refer people out and their insurance will pay for physical therapy with no copay. It's free. And the physical therapist sees them 3 times a week. I can't see patients 3 times a week. I don't got that kind of time. So as far as it working, absolutely. As far as it being an awesome tool, absolutely, definitely. If you don't have it, do you need it? No. If you've got it, could you use it? Absolutely. That'd be my answer.
Great. That's fantastic. One of the questions here is, will there be a recording available? We do post this on our YouTube page and our snoozle for if you're a DS3 member. So there will be, if you want directed towards that, again, you can contact us at the info at Dental Sleep Solutions. Just a couple more here. I think I'll answer this one, but then you'll give the real answer. If a patient presents with TMD, is the tap the best appliance to use? And the answer is, it depends.
It depends. Yeah, so I'm not sure why somebody would
Yeah.
ask in that way.
Right.
So unless they've been told, unless they went to a course where TAP said, this is the best one to use in a TMJ patient, which I would then definitely take with a grain of salt. So it depends on your diagnosis. What's causing the problem? Does it have anything to do with the oral appliance? Now, here's something I will say, though. So I really love that whoever asked that asked it in that way, because the question that we used to have is, so here's a little pearl for our little history that people might think is interesting. So I'm one of the founders of the Tufts Dental Sleep Medicine mini residency. And you know why I founded that, Guy?
I do not.
Because it used to super piss me off that I would go to dental sleep medicine meetings, and from the podium, it would be said over and over again, thou shalt not treat a patient with an oral appliance if they have a TMJ problem.
Yeah.
And I was like, what the heck are you talking about? We do this every day. And all of us that were doing a lot of TMD, we knew that these things were related. This wasn't a contraindication. This was no problem. And so I called up Nasher Mehta, my mentor at Tufts, and said, dude, we got to put something together here and stop this silliness of that you can't treat a patient if they've got a jaw problem. And so we started that program a decade ago. So I love that the question was, should I use this appliance, rather than I can't use an appliance. So the answer is, you can use an appliance. There are almost never a jaw problem that I'm scared of treating them with an oral appliance for their sleep apnea, because my paradigm is their sleep apnea is probably one of the biggest causes of their TMJ problem. So if they've got a protected airway, that is almost assuredly going to help their jaw problem. Not always, but depending on the etiology, that could make a huge difference. So the TAP might be a fine choice for that, but also so could many others. I'll give you one pearl, though, is a common mistake is people putting someone in an appliance that does not allow any lateral motion, and that patient has a history of lateral bruxism. So you see wear on their canines, wear on their cuss tips. They're a lateral grinder historically. We don't know if they are every night, but historically, if they've done this, and then you put them in an appliance that doesn't allow them to move side to side, that patient can develop a synovitis or muscle pain because they just have nowhere to go, even if their airway's protected. So the way I like to say it is, I always choose an appliance that will allow them to continue their bruxism behavior, and then I hope that they stop it when we protect their airway. But I know from experience, and so do you, Guy, that there's plenty of people out there that we protect their airway, their AHI may go to 0, as a matter of fact, and they still grind the crap out of their appliance. So I prepare for the worst and I hope for the best.
Fantastic. The only comment I'll make on that, I agree completely. Thank you for your work trying to get the word out that TMJ problems aren't a contraindication. Some insurance companies still believe it is. And so if you put that in the notes, be aware it can cause a claim to not get paid, and then you can argue until you're blue in the face and you may not win that one.
Thank you so much, Guy. And I think in your software, you've put that in there, because that's a problem. Is right now, a lot of you have a box on your intake, and it's like, do you have a TMJ problem? And the patient's like, well, yeah, my jaw clicks when I eat beef jerky. And so they think that's a TMJ problem. Insurance sees that, denied, because the silly FDA says you can't treat with an oral appliance if there's a TMJ problem. And you're right, that's showing up in a lot of insurance companies' policies. So I always note, if the patient has had a problem, I will put in there not clinically significant, or has never required treatment, or that the patient has a history of a jaw problem that never required treatment and is not currently active. And then that way, you're safe. But if it just says,
good words,
something about the patient having a TMJ problem. You're right, Guy. That's a tough one to get overturned.
All right. Well, it's. I think that's all the questions. Yeah, I think we've gotten most of them. I think we can close with. I guess someone's audio cut out with the lip closed, teeth.
Lips
Teeth
together.
apart. Yeah, lips together, teeth apart.
Lips together, teeth apart. That is the whole ball game.
Yeah.
and with the whole sleep apnea thing too, there's a lot of interest now with nasal breathing, and some people are taping lips shut and stuff like that. Lips together, teeth apart, man. So if we can breathe through their nose, if they have their lips together, if they have their tongue up in their palate the way it's supposed to be, that's the stuff. That's where it's supposed to be. If we can train them to do that during the day, maybe they do that at night. At our Spencer Study Club meeting on Thursday, we're having a session called Practical Myofunctional Therapy, where we're teaching just the exercises, 2 hours of here's how to do it. None of the, 3 days of why it matters, just 2 hours of here's actually how to do it. And I think it's really important. I think that these things are very important. And again, from the TMJ side, lips together, teeth apart. That if you can get your patients to do that, a lot of these things get better almost automatically.
Well, that's fantastic. Well, I think we got most of the questions answered. Hope to see you all in Baltimore. Come by. I think our booth is 300, if I'm not mistaken. And you have a booth there too?
We do. I don't know what the number is, but it's going to tell you. It'll be pretty easy to. So it's Spencer Study Club, and it will be relatively easy to find us because I'll just say this: look for the Yeti.
The Yeti.
Look for the Yeti. If you see a Yeti, follow that Yeti, and you'll probably find our booth.
I'll have to bring my son. He's been looking for many years for one. So.
Okay. About to find
well,
one.
I really appreciate you doing this with us tonight. I learned a lot myself. Thanks also for your help with putting our TMD together for DS3. Thanks in advance for your help with our members who we can direct towards Spencer Study Club for as they want to continue their learning in TMD. And I look forward to seeing you in a couple of days. Everyone, if you have any questions, don't hesitate to contact us at Dental Sleep Solutions in DS3. The information is right there on your screen. We're happy to answer questions, happy to, if you just want a consultation and want to know what's, where you are in your sleep practice and how we can help, and just let us know by contacting us, and we'll set up some time to talk to you about your sleep practice and TMD concerns. So I think that's it, unless you have anything else to say.
No, that's it. Again, thanks for having me on, and I really appreciate it. And as one of the few people that's seen the TMD module in DS3, it's cool. It's cool stuff.
Fantastic. Well, I think, Jamison, you're in control, so you could hit the end meeting button, and we'll all go do what we do at 9:30 at night in Eastern Time Zone here.
Okay. Jason might have to get on and help us here. It's because
I think I can do it. Let me see here. Got a dual screen open, so maybe I can end it here.